Hi, Dr. Dorgu. Would you like to test your presentation?
Hello, can you hear me?
Yes, I can. I was waiting for you to test your presentation.
Have you got it with you? I sent it ahead.
Yes, I do. However, we preferred the option of everyone sort of presenting and sort of doing it yourself in terms of changing the slides and the pointers.
Oh, I see. Oh dear. Okay, let me look for it.
If you want, I can do it for you, Dr. Dorgu. It's Mike here.
Okay, hi Mike. That would be helpful.
Is that easier for you?
Yes, please.
Okay.
Let me see if I can find. It's just that I had I was involved in a CPD yesterday, and two of the presenters had problems sharing their screen.
Fine.
So yeah. So
We've
it might be
got it
easy.
anyway. We can do it for you if you would like. To.
Yeah,
Just
thanks. And
prompt
my
us.
Wi-Fi here has been temperamental, I must say. So
Okay. Just prompt us with the next slide, please, and we can do so for you.
okay, thank you.
Thank
I don't
you.
have that many slides anyway.
No,
Thank
not to
you.
worry. Thank you so much for joining.
Thank you.
So we are your fail-safe mechanism. Mike, would you like to just try and see if you can try Dr. Dorgu's presentation? Chinenye, you're welcome. Do you have your slide ready to present as well? I am going to make you co-host.
Can't hear you, Chinenye, you're on mute. There you go.
We still cannot hear you, even though you've unmuted yourself.
Can you hear me now?
Yes, we can hear you now.
Okay, thanks. Sorry, it wasn't letting me unmute myself before I was given permission. Sorry. Do you want me to share my screen? I'm happy to do that.
Yeah, right now. So you can just actually share a presentation and make sure your mouse is moving.
Okay, yeah, that's fine. Bear me 1 second.
Thanks for joining, Chinenye. We'll see you're still in hospital.
Always. I live here now.
Don't we all, eh? Don't we all?
Just bear me 1 sec. I just need to get it off my email. Sorry. Because I wasn't sure if you wanted to do it yourself or you wanted me to, but I'm happy to. Can you hear me clearly? I'm a bit concerned about the network here.
I can hear you loud and clear. There you go. And can you make it full screen as well?
That's not mine.
That's not hers, that's Dr. Dorgu's.
1 second, I'll get mine up.
Well, you can present for her if you would like.
I don't know anything about kids, I'm afraid, apart from my own. Okay. I will be whizzing through it because obviously it's only 10 minutes, so it'll be a bit of a whistle stop, but I think that should be fine. Gosh, this is being very slow, which is a bit concerning.
And Laura is here as well. So Laura, if you can hear us, we're trying to arrange it so you have the option to control your own presentation. So you'll have to share your screen after Chinenye has shared hers, and then just make sure it's all working for you.
So, Mike.
Yes, sir.
You're sharing your screen. You can stop now.
Okay.
Thank you. Professor Kinnair, I'm going to make you co-host, and I want you to also confirm that you can share your screen and your presentation as well. Bishop Dorgu, I've also made you co-host, and so just a quick roll call. Chinenye is here.
Yes.
Yeah.
Yeah, Dr. Dorgu is here. Professor Kinnair is here. I'm yet to
Laura is also
see-
here.
Oh, Laura, there you go. Let me find you.
Dr. Ikpoh is here. And
Yeah.
Bishop Dorgu is also here. So all our panelists are here. And we've got a Daniel Sigbe joining shortly.
So Laura, I've just made you co-host. Laura, can you confirm that you can share your presentation? Margaret, the spotlight is on you. You can confirm you can share your presentation as well.
Sorry, just bear with me. Something's happened.
Oh, no problem. So of course, during the presentation, if we have sort of any unexpected disturbance, I'll just mute everyone and then unmute the actual speaker at that point, assuming my phone starts ringing. And at this point, whoever is presenting will just unmute himself or herself and then resume the presentation.
Mike, can you come back to me? Sorry.
Okay. Sorry. Yes, I can share.
Yeah, sure. All right. So, Chinenye, I'll go back to you again.
For any of our speakers, if you have any difficulties, we can do it for you. I know most of you prefer to do it yourself, but we can do it for you if you would like.
Can you hear me?
Yes, I can.
Yeah. You might have to share it on my behalf because it's being very slow for some reason and I don't want any sort of halts or hiccups.
No worries, I can do that for you.
Thank you.
Do you want to try it, Mike?
I can do, give me a moment.
Sure.
Hi, it's Margaret here. Can I ask for the same?
You can indeed.
Only because I want to say next slide, please. Don't we all?
Thanks, Mike. Yeah.
That's all right, you got it?
Yeah.
Good.
Sorry. Can I just ask if I can just try sharing mine and just make sure it's all okay?
Okay, so I'll stop sharing that. Laura, you take over.
Okay, that's great. Thank you.
We've got 6 minutes to start it. I'm glad that everyone's here on time and thank you for all our panelists for taking time out to join us on time. Excellent. Thank you, Laura.
So can we see that okay? Is that okay?
That's perfect.
Yeah.
Fantastic. Okay, so I'll control mine. Thank you.
Lovely. So you can stop sharing now. Thank
Okay.
you. There we go. That's worked out quite nicely.
I guess, as we all know, whenever you say next slide, sometimes there is sort of a 30-second delay between the next slide and when the slide actually changes. So just be smooth with it, okay? All right, Mike.
I must thank everyone for their engagement. We're still getting, up until this minute, questions to the ManSag email address that people want to discuss. Hopefully, most things are covered in that time, and we'll answer as many questions as we can. I'm Mike, by the way, the guy who's been disturbing all our panelists. Hi.
Hello.
Thank you all so much for joining.
Nice to meet you.
We've got 5 minutes to start, so make yourselves comfortable. And we'll see you shortly.
And Mike, you have the spotlight.
Thank you very much.
Wow.
I think we are just coming to 7 o'clock. I would like to thank everybody again for joining us on time, and in a lot of cases, joining us very early. I also want to take the time to thank our panelists and our speakers for giving us their time. COVID has been a difficult time for everyone. The multiple lockdowns, the effects on businesses and people's daily lives. And unfortunately, we have lost many friends, many families. But as a vaccine has arrived, some people have seen a ray of hope. And I've had the vaccine. I know many of my colleagues have. But we do know that there is significant distrust and a lot of questions left unanswered by people about the vaccines. And the hope is that today we can hear your questions. We can talk to you about the vaccines, tell you about what they are, and answer the questions that you may have. and hopefully we can, positively affect you and influence you and get going. So without further ado, I would like to welcome our first speaker, Dr. Chinenye Ilozue, who is a infectious diseases and general medicine specialist. And she'll be talking to us about COVID and where we are at the moment. I'll just get your presentation up for you. There we are.
Okay, hi. Good evening, everybody. Thank you for joining us today. My name is Chinenye. I'm one of the infectious diseases doctors. I'm working in the UK at the moment. So the point is going to be a bit of a whistle-stop tour, but really the point of this part at the beginning is to go through essentially what we know about COVID so far, and also, highlighting the much that we do not know. And also I wanted to also focus a bit down on we're talking about vaccines today. So I wanted to just give an overview about the biology of the thing, so that helping to understand the biology helps to understand what we're doing with the vaccines, which essentially should help to sort of alleviate some of the concerns about, the new technologies, etc. So next slide, please. So just an overview, as I say, I'm going to talk a little bit about the virus itself and how it actually infects us. So the virus, the host, that being our cells. I'm going to talk a little bit about the numbers. We know how devastating this has been, both here in the UK, but also the global impact. And then I'm going to talk a little bit about where we're up to with treatments for COVID and what we're using in clinical practice today and what's also in the pipeline. And then talk a little bit about the other side of things, particularly the new variants, which is obviously causing concern. So SARS coronavirus is the severe acute respiratory syndrome, coronavirus 2. The coronavirus original, as it were, was the outbreak in 2002 that happened in East Asia, also started in China, Singapore, Hong Kong, etc., and spread to many countries in the world. And similarly, it's in part of the family called the beta coronaviruses, which also includes MERS, which is the Middle East syndrome of respiratory syndrome, which also had a major outbreak in 2012, and we've had clusters of cases in Korea as well since then. And as I say, SARS-CoV-2, as we all know, was first identified in sort of December in China, in Wuhan, and has, as we know, the situation is as it is. Next slide, please. So this is just an illustration as to the sort of relationship between the different coronaviruses. There are many, and the ones highlighted in red are actually the common cold viruses that circulate throughout each winter, essentially circulate in our countries and throughout the world. And the one in green is a coronavirus that causes bronchiolitis and also pseudocroup in babies. And as you can see, sort of further down the line is SARS, which is closely related to the original SARS, and MERS as well. So it's just an indication as to this is a coronavirus. We're familiar with coronaviruses, and there's been lots and lots of research, both from the SARS outbreak from 2002, but also the common cold viruses, which are also part of the same family. Next slide, please. This is a bit of biology, and I know we have a mixed audience of clinicians and non-clinicians, and I don't want you to worry too much about the detail of this, but it's basically to explain what happens when the virus meets our cells, what happens when we inhale the viral particles into our nasal mucosa and it meets those mucosal cells. They've just asked me to slow down a bit. I'm just trying to get through it because I know questions are important, but I will try and slow down a little bit. So at the top there, I don't have the mouse to control, but the top schematic that you can see is the virus with the little red spikes, which is essentially everybody's heard about this spike protein. And it's that spike protein, this rectangle in the middle of the screen, is our cell. And that spike protein is what attaches to the ACE2 receptor in our cells. So when we inhale the virus, it's droplet aerosols, we're inhaling it into our nasal mucosa, into our mouths. As it touches the cells, that's how it enters into the cell, the viral particle. And that spike protein, the virus then enters our cells, and this is what all viruses do. Viruses cannot survive outside cells. They have to replicate, and they have to basically replicate themselves and amplify themselves within the host, which is us, the human cells. So it attaches, it then fuses, and it enters the cytoplasm. As it enters the cytoplasm, the RNA, and the RNA is the genetic material, it's a specific type of virus, which means it can make proteins itself directly from its genetic material. It doesn't need too many enzymes, it doesn't need too many steps. So that's why I've put at the top positive sense RNA virus, because it directly translates That's one of the reasons why the mRNA vaccine has worked for this type of virus. So the genetic material comes out of the virus while it's inside our cells, and then essentially that then gets translated into proteins in the cell using our cell organelles, and then a new virus is assembled based on that replication inside the cell, and then that virus is released, buds out and released from our cells. And that's what normal viruses do. That's what essentially all viruses do. And that's why the mRNA part that's injected in the vaccine is what works in this similar fashion. It's almost a model for how that works, because it's what the virus itself actually does. And just the little star at the bottom, right at the bottom, is just I know there's been lots of concern about it affecting our DNA, the DNA in our cells. The DNA in our cells is far, far away down in the bottom of the nucleus. So all this process is nowhere near our own cell's genetic material. Next slide, please. So this is just, again, just reiterating that, just in a bit more detail, but I won't go through it because I want to get through the content so we can get to the questions. Next slide, please. So just thinking about COVID as a disease. So SARS-CoV-2 is the virus itself. It's what we call the virus, the coronavirus. COVID is the disease that it causes. So you get infected with the virus. Some people, as we know, will have asymptomatic infection. So they will have the virus in their bodies, but they won't actually have the disease, but they can absolutely pass it on. But unfortunately, as we know, with the devastating effect of COVID and the devastating mortality of it, it causes disease in a lot of people. So essentially, this is the time course, as it were, of COVID infection. You get infected at the beginning, it enters into your nasopharynx. You have a pre-symptomatic phase where up to 5 days before getting symptoms, you can actually be shedding the virus and passing it on to others. And then at that point, your viral load is very, very high, and that can be detected, for example, with the lateral flow assays at that point. And then you develop an illness. It could be mild to moderate and you could completely settle down, or it could then progress into the severe illness and the critical illness needing ITU stage. And it's at this stage where the actual virus itself is not so much present in the body. The blue line, the light blue line, is sort of the level of the virus, but actually it's the body's immune response and that hyperinflammation of the body's immune response to the virus that is actually causing the respiratory syndrome, the respiratory distress, and causing that deterioration and the sort of devastating respiratory failure that we see in these patients. Next slide, please. I'll try and speed up a bit because there's a bit to get to. So we know about the pandemic, we know the numbers. The size of the circles just basically represents how badly each country has been affected. Next slide, please. There was a question saying, is that the cytokine storm? Absolutely. Cytokine storm is part of one of the manifestations of the severe sort of acute respiratory distress syndromes that happens towards the end of the spectrum. And this is just data from yesterday, actually, on the Public Health England website, gov.uk, showing the hotspots. So in purple, the highest, sort of 800 per 100,000 population. And then the green is the lowest numbers. So that's sort of where we're up to in the UK at the moment in terms of where the numbers are. Next slide. And again, all of this is just freely available. You can just see the case numbers at the bottom. And then at the top, I just put in a slide about how many have been vaccinated. This is, yesterday I looked this up. So almost 7 million have had their vaccines so far, first dose, which is a good going number, really. So let's talk about treatments. As I say, I'm running out of time, so I'll try and speed up a little bit. So at the moment in clinical practice, there's 3 treatments that we're routinely using as treatment, as in outside of clinical trials, but there are many, many more agents that are still being evaluated within the context of clinical trials, which is how we get the data as to, 1, does a treatment work, and 2, is a treatment safe? So the efficacy and the safety is what's important. So dexamethasone is essentially the star of the show and still remains to be so from the recovery trial, which has shown up to a 1/3 mortality benefit. So a 1/3 less people will die if you give them dexamethasone when they come into hospital with COVID. Remdesivir is the antiviral, so it works best at that. Remember, the beginning is the viral stage where the viral load is higher. So remdesivir is something that we are still using in clinical practice. The data and the efficacy is contentious, I have to say, but certainly here in the UK, we are still using it. And then at the bottom is tocilizumab, which is essentially as a monoclonal antibody against IL-6, which now has been approved for use in critically ill patients, but has also been evaluated in several different trials with slightly different results, some showing mortality benefit and some, like a Brazilian study that was released in the BMJ just last month, showing that it may not make a difference. Next slide, please. So I'm just going to talk a little bit because there's been lots of talk about different ages for agents, from hydroxychloroquine, azithromycin, zinc, ivermectin, lots and lots of talk about what works, what might work, what can we use here, what can we use in Nigeria or the continent of Africa. So someone's written ivermectin, so we're going to talk about ivermectin in a minute, and I will try and sort of temper the language. I understand that, as I say, we do have non-clinicians here. So this is just to explain about the recovery trial, and that's a trial that's essentially run from the UK, but it's an international trial. So far, there's been 32,300 patients that have been enrolled in the trial, and we enroll patients every day. And essentially, it's to look to see what works with COVID, what makes people better, what stops people dying, and what essentially reduces their length of stay, both in hospital, but also the clinical disease itself. So I'm sure you've all heard of, the azithromycin and the hydroxychloroquine from previously. So the recovery trial, and we're still looking at, in the recovery trial, at colchicine, aspirin, and monoclonal antibodies. Azithromycin was shown to not have benefit from the thousands and thousands of patients that received it in the trial. Next slide, please. Kaletra, again, I'm sure lots of you remember back in sort of towards the beginning of the pandemic last year, a lot of people were talking about Kaletra, which is an HIV drug, but again, it was within recovery trial, and last year it was shown to have no benefit. Similarly, hydroxychloroquine, but there's still lots of meta-analyses, so combinations of different trials looking at these drugs. And as I say, convalescent plasma and tocilizumab have recently recruited thousands of patients, and we're waiting for that data. Ivermectin is the one that lots of people are talking about now. It's sort of the current thing. Yeah, next slide, please. So just going back to ivermectin, which is the current thing that lots of people are talking about, especially for Africa, because it's obviously widely available as an anti-parasitic agent that we use for worms and lots of other parasitic infections. So there are lots of trials ongoing and lots of media interest, just like there was for hydroxychloroquine a good few months ago. Next slide. And just to explain, the National Institutes of Health, the NIH, which is the US-based sort of international research, they made a statement just this month, next slide, which was, a lot of people are saying it's an on-the-fence statement, and it's essentially what we see all the time. Essentially, they're saying they cannot say do use, they cannot say do not use ivermectin because the data is not there. So essentially, we need the clinical trials, we need the well-conducted randomized controlled trials so that we can provide that evidence-based guidance for whether ivermectin actually works or not. We know that it works in vitro. So in a laboratory, ivermectin and a SARS-CoV-2 virus, it will neutralize the virus. It will stop the virus working in a lab, in a test tube, as it were. But that doesn't always translate to clinical efficacy in a human being. And that's the thing, that's the step that needs to be evaluated. Next slide, please. Next slide, please. So the last thing really I want to talk about, because I know that we have limited time, so I just go back one slide, is the new variants, because obviously that's also causing lots and lots of problems. So I just wanted to touch on the biology of a new variant. And again, I apologize. I know sometimes, this is a little bit, it's a lot of science and a lot of biology, and we do have a mixed audience. So if you could just go back one slide. So the The ones that everybody has heard of are the 3 new variants. Obviously, the one in the UK. Don't worry too much about what the actual numbers are, but it just represents where the mutations occurred. So UK, so that's a sort of map from yesterday about where the UK variants have been found. The South African variant as well, so that's also a map as to where that's been found in the world, and also Brazilian variant, which was essentially the hotbed of it is Manaus in the Amazon forest in Brazil. And GSAID is basically the genomic surveillance, the international genomic surveillance that every country uploads their data to, so that we have real world information as to where these variants are. And each lab that is sequencing uploads so that we know what's going on internationally. Next slide. Next slide, please. So the variants occur, I'm nearly done. The variants occur because basically that string of genetic material in the virus, it copies itself in our cells, just like that picture that I was showing. Each time it copies, there's a tendency for there to be a mistake at some point along that string of genetic material. So that's why mutations happen. And often it can happen just as an error, and it often means nothing because it's 1 or 2 base pairs, as it were. And sometimes it happens as a result of what we call selection pressure, which means the virus is trying to escape, it's trying to propagate itself and make sure that it can still transmit. So things like, making sure it becomes resistant to treatments, etc., things like that. So there is a suggestion, and we know in science that these type of coronaviruses actually change more slowly than other viruses like influenza and HIV. RNA viruses as well that have the same type of string of genetic material. And it's one of the reasons why we've got, thankfully, a coronavirus vaccine. And for example, it's very difficult to get an HIV vaccine. Next slide. So some experiments can suggest that some of the variants, as I say, there are many, many variants, but some of the variants can infer increased infectivity. So remember that red spike at the top of the ball of the virus, that's the spike protein that attaches to our cells. Sometimes the change in the genetic material can change the shape of that spike and give it more affinity to attach to our cells, which means it's more likely that we're infected with the virus. And some experiments suggest that some of the variants may do that. Next slide, please. So why is it occurring? We know, as I say, I mentioned GISAID, which is the International Genomic Surveillance. Over 90,000 isolates, probably more, because day by day we're getting more, have been sequenced and made public. It's all available there if anybody wants to see. There are over 12,000 already mutations in the SARS-CoV-2 that we know about. And many of the mutations don't mean anything. They mean nothing clinically. They don't mean anything about the virus's ability to spread or cause disease. They don't change the shape of any of the proteins. It's just what happens when it's copying and there's an error. There's also a new variant that was found in Nigeria. I'm not sure if people are aware, in Osun State. It was reported in December, but it was actually detected back in August and October as well. It's a link to the UK lineage, UK variant lineage. And then again, it was just found in that region. And similarly, more recently, the most latest one we've heard about is Japan. Next slide. So that's really most of what I wanted to say about COVID and the biology of COVID. We know the devastating impact. We just had the grim news yesterday of 100,000 deaths in the UK alone, let alone internationally. So our job now is to think of a way us as a community, us as a public health community, but also healthcare professionals, and all of us as human beings can get out of this, really grim situation that we're in. Thank you.
Yes, thank you so much for that, Dr. Ilozue. That was very helpful. I know there's a few questions that will come up, certainly about ivermectin and the different mutations and what that means for vaccines. And there's a few questions in the chat, but we'll have some time to come to that already very shortly. So just to introduce our next speaker, who is Dr. Mosun Dorgu, who is a consultant child and adolescent psychiatrist And she's going to talk about something that we don't often discuss, which is the impact of COVID on children. And hopefully we get to hear some interesting things from you. I'll share my screen for you. I'm quite getting used to this. Next slide, please, business. Can we see that? Excellent. You're on mute, Dr. Dorgu. You're still on mute. You can't unmute it. I think, Chris, you might have to unmute her.
Yes, I'll do that right away.
Thank you. Is the master who holds all the keys.
So, Mike, could you stop sharing your screen for 1 second?
Okay.
Thank you.
Thank you.
Lovely. Can you still see the screen, or should I share? I'll reshare.
Yes, reshare your screen.
Yep. Okay. Good evening, everyone. Can you hear me? Yeah. Good evening, everyone. I'm a child psychiatrist in London, and I work in a busy setting, mixed population, inner city. Next slide, please. So I'll be talking about the impact of COVID in children and adolescents. So the age group is pretty much 0 to 18. In the past year, the COVID-19 pandemic and its effect have dominated news headlines around the world. To date, the media focus worldwide has been mainly on the impact of people's health, and sadly, there have been fatalities. However, there has been less focus on the impact on mental health and well-being in general, and more so, less focus on the impact on children and young people. As we know, children tend to be perceived as the Cinderella of most professions, so they're hidden away. There's a myth about children's presentations and that sort of thing. And unfortunately, the approach to issues and challenges faced by children and young people is not new. There have been several studies in adults to date since the pandemic started about a year ago on the impact of COVID, but unfortunately, there is a dearth of studies in children and young people. Even with the adult studies, a couple of thousand studies have been done, but only a handful of them, actually less than 2 dozens, have met rigorous research guidelines. So that there aren't that many studies in adults that we can refer to in terms of impact, let alone children. The information shared in this presentation is based on some comparative studies in children and young people pre-COVID and in the middle of the current COVID pandemic. The main reference is from the Lancet. There's a publication just this month. And Young Minds. Young Minds is a mental health charity that deals with children and young people, but the focus mainly is on those with mental health difficulties. And then there have been anecdotal reports from peers, colleagues, and even people who use our services. But unfortunately, we're still at the early stages of putting the information on children and adolescents in a comprehensive format. In terms of the impact, I'd like to look at the impact with regards to the short-term, medium-term, and long-term impact. And in some cases, there might be an overlap. I must say that we're not quite sure of what the long-term impact is, COVID-19 has only been around for a year, but these are just projections. And then in 3 categories: physical health and well-being, psychological and emotional, family and socio-economic impact on children and adolescents. As regards physical health and well-being, I'd like to say that mental health is everybody's business. We all have mental health, but some people tend to perceive the word or the expression in a negative context. We all have mental health because we all have feelings and emotions. And the WHO definition of health is that it's a state of physical, mental, and social well-being, not necessarily the absence of disease. So we need to bear that in mind. So in terms of the short-term effect on physical health and well-being, some children have had COVID. Anxiety symptoms. Anxiety symptoms present with physical features such as some children might complain about headaches, butterflies in their stomach, wet hands, shakes. And so as parents, carers, school teachers, if a child presents with what we might think are due to physical health problems, they might actually be secondary to anxiety. And then there have been issues about access to services, not just mental health services, but physical health services in general. At the start of the lockdown, the pandemic, we had to follow strict government guidelines to minimize face-to-face contact within GP settings and within mental health settings. And unfortunately, lots of children that we would normally have seen within the clinic setting were not offered that privilege. And so since the pandemic, most of our appointments have been done virtually via video link appointments or telephone calls. Priority has been given to urgent cases that present in hospital, mainly A&E or pediatric services. Those are the sorts of young people we tend to see face-to-face in general. We cannot overstate the impact on education. It's been on the news, was on the news today, and the lockdown has meant school closures, and only children of essential workers in the UK, frontline staff, have had that opportunity to have, in quote, uninterrupted education. There have been increased referrals to services, and there was actually some information released last week to say that some mental health services have had the highest number of contacts, be it by video, face-to-face, or telephone contacts since the records began. So in terms of short-term psychological, emotional isolation, as we know, young people have, a lot of young people, the feedback we've had is that they've missed that one-to-one interaction with their peers, and even the face-to-face is not just with services, with peers, with relatives, extended family, grandparents, and a lot of them have said it makes them feel sad. Low mood has been associated with the COVID pandemic, low self-esteem. In terms of family and socioeconomic, we cannot overstate the fact that there's poverty, inequality, and the COVID pandemic has brought this to the surface. So we have lots of children and young people living in poverty in the UK, and I can imagine the effect in terms of the impact in the rest of the world. Then relationship difficulties. It's been hard for families, parents working at home with children by their sides. It's just been very hard, some living in very small spaces. And then physical contact is very important, But unfortunately, I have had colleagues who are nurses say, they get home from work, their children are not allowed to give them a hug. That is quite distressing for them psychologically, and they've had to explain to these children. Then loss of employment of parents. We know lots of people have lost their jobs and some parents are on furlough. This creates stress within families. In terms of the medium term, children who normally have had issues with school would then see it as an excuse, a legitimate reason to miss school. And there are studies to show that even after the lockdown eased and children returned to school, in a certain study, 16% of children who had the opportunity to go to school did not return to school. And in terms of mental health and well-being, unfortunately, we have vulnerable children with pre-existing or underlying mental health difficulties, some with social communication difficulties, such as autistic spectrum conditions, epilepsy, learning difficulties. They also have been badly hit by this pandemic. And this has been highlighted in a Young Minds survey that was done in 2020. Medium-term psychological emotional, as stated before, loss of friendships, bereavement and loss. Lots of people have lost loved ones, friends, relatives, and have not been able to say goodbye to them because of social distancing, even when it was obvious that they were dying in intensive care. And then some people have tended to self-medicate, and I would say maybe possibly due to the reduced access to services. So self-medication could take all sorts of forms, over-the-counter medication, unfortunately and sadly, substance misuse, and adolescents are very vulnerable in terms of abusing substances. And then in terms of medium term, the stresses on families, loss of jobs, small spaces have led to domestic violence. Just in the last 24 hours on the news, it's been stated that there's been a 25% increase in safeguarding reports or calls to the police and other services, social services. And also, I need to state that the loss of the network has made children more vulnerable. So family network of the extended family and also the school. Schools, we tended to get lots of referrals from schools, but when schools have been closed, there's been a drop in referrals, but these referrals have been made by GPs or even self-referrals have increased because that safety net at schools has been temporarily suspended. And so, as I said earlier, long-term effects the extent is yet to be predicted. We need longitudinal studies to decide what the long-term impact of COVID is, but predictions indicate problems with education, unemployment, homelessness, long-term mental health problems, stigma. Some young people in colleges have been stigmatized by their peers just for being quarantined for 14 days. You won't believe it. Then post-traumatic stress disorder is also another long-term effect. And then criminality, there are children who are already vulnerable to conduct disorder, which is bad behavior. And they end up going down the trajectory of criminality. And sadly, parental separation and divorce. Next slide, please. This is just a summary of the impact. So pre-COVID, a survey was done of children and young people in England between the ages of 5 to 16 in 2017. In general, mental health problems across age, gender, and ethnicity was 10.8%. And there has been an obvious increase as a result of the COVID pandemic. And it's 16, in a 2020 survey, it was 16.0%. Next slide, please. These are just examples of problems that have presented to our children's services, mental health services, and GP services in the past year, just as a result of COVID. So some of these problems are problems that are usually found among children and young people, but they've all increased. So sleep difficulties, children these days report nightmares. They watch all sorts of scary things on television, social media, even just the information. There's information overload due to access to technology. Most children, some as young as 5, toddlers, have smartphones, believe it or not. Some even have iPads and they're glued to them 24/7. Some parents, unfortunately, don't put filters or barriers, to protect these children. So they're exposed to things they shouldn't be exposed to, and that causes trauma. So their brains are already being traumatized at a young age, and we don't know what the long-term impact will be. Boredom, worries, anxieties all increase. But it's interesting, the only, of all the impact studies, the only one with a mixed report was school attendance, because there are some children who've never liked going to school. So for them, COVID has been their get out card, so to speak. So they've found it more relaxed to be at home, and they've reported they'd rather be at home than at school. So for them, that's been a positive impact. Next slide, please. I'd just like to spend a few minutes on the socio-economic impact, not just on children, but on families in general. And I'm sure we've heard this on the news, more so in the last 24 to 48 hours. Sadly, some young people don't even have any access to internet services. So how are they supposed to do their homework or their schoolwork at home? And then some young people have no quiet space to work. They share bedrooms with their siblings or other family members. It's so difficult. And last but not the least, some don't even have a desk to study at home. And then in terms of poverty, inequalities, sadly, the results show that there's an overrepresentation of these inequalities and disadvantages in the Black and minority ethnic communities. And there are lots of children across the spectrum whose parents have had to resort to food banks more than ever before in the last year. Next slide, please. So in terms of next steps and suggestions, please note that this list is not exhaustive. Your ideas are welcome. You can add thoughts, ideas, suggestions to the chat. I'd like to propose that well-being and mental health awareness training for parents and teachers should be high priority in most countries, because children across the world have been affected, and usually the first port of call is their parents or teachers. So the parents themselves need to be armed to deal with these presentations. And then there's a need to build resilience in children and young people, and including parents and carers and family members in general. And we need longitudinal studies to understand the possible long-term consequences of the COVID-19 pandemic on the mental health and well-being of children and young people. And there's a need for early identification of mental health problems. Thank you.
Thank you so much, Dr. Dorgu. That was very helpful. Certainly, we're seeing a lot of the cases as you've described in GP land, in hospitals. So we're very aware of what's happening. I think we definitely need to be more aware of it and more careful with the things that are to come in the future. Next, we have Professor Dame Donna Kinnair, who is the Chief Exec and a General Secretary of the Royal College of Nurses. Thank you so much for joining us. I specifically wanted you here because I also work in hospitals, both in Northwest London and in Newham. And when I sit with my nurses, most of whom are BAME colleagues, the distrust of the vaccine in general is palpable. And I think if we can get through to that group, we can get through to a larger group. So I thought it would be best to hear from you. So thank you so much for joining us. You're on mute, so we'll have to unmute you.
I think I've unmuted myself. Can you hear me? Yeah. Okay. Thank you so much for inviting me to speak with you and our fellow panel members. And I'm not going to pretend that I'm a scientist or a doctor. I'm going to talk to you as a nurse and as a unionist, as the Chief Exec and General Secretary of the Royal College of Nursing. And I really want to thank everyone for coming, because everybody is stretched. And so making the time to be here this evening, it shows the importance of these conversations. But it was only Monday that I was contacted by a colleague that you may well know, Mike, Sam Everington,
yes,
in East London. Yeah. And he actually, I wish I could show you, it's on my screen, but he actually showed me the data of the cumulative COVID vaccination crude rates in the age groups that have been vaccinated so far in Northeast London. And if you look at the graph, actually, you'll see it starts with mixed race running along the x-axis. And then I guess it's less than 10 per 100,000 of the population for Black. It rises to about 40 for Asian. It's about 120 for male whites and 140. So actually it shows you from that how limited our take-up is. And I'm actually also a NED on the East London Foundation Trust. And what I'm hearing throughout the whole of East London is that our take-up for BAME colleagues is lower, even for staff. And I have to say, I'm concerned about this, not just because of what the graphs are showing, and not because of the fatalist emails that I get on a daily basis, but I think it's important for us as Black leaders to really bust those myths that are out there. Now, this pandemic has shown the best of nursing and medical care that we've ever seen. And we knew by about April, May, that actually, for some reason, the BAME community was being disproportionately affected. You only needed to look on TV and see the 10 first faces that they put up on our television. They were all doctors. They were predominantly from the BAME community. And so we knew that whether it was multifactorial, that actually we needed to look at this. And I don't think it was, I think it was about the beginning of May that the head of the NHS called a meeting where he was very concerned. I guess he was on his sickbed with COVID, watching the TV programs and seeing who was being disproportionately shown on those television programs. So I think it's been challenging for us as professionals. And not only has it been challenging for us as professionals, but personally, I don't think there are many communities across London that haven't been affected by COVID-19. And I think the dedication that frontline staff has demonstrated during the pandemic has made me incredibly proud to be a nurse, and particularly to be running the Royal College of Nursing. But one of the things that I want to say is that it's incredibly important that we recognise that a safe and effective vaccine is now available. And I don't think we should hide from coming out and saying that. I'm going to just mention to you that actually I've been sort of dancing around at the top of the NHS for a while now, but come April, when I realised that as a nurse with skills in intensive care from way back then, that I could be useful, I did go and work at the Nightingale. And all my colleagues said to me, Donna, it's not the same as an ITU. And they said, you will be terribly affected when you walk onto that floor. And I'm like, look, mate, I've been a nurse 35 years. What are you talking about? I've seen it all. And in the days when I started nursing in the art, you know, I came in the HIV phase, right? And people were dropping like flies in the London hospital. So I was like, okay, this is not going to be very difficult for me. And oh my God, when I walked onto that floor and I saw row after row of Black men being ventilated, I started to walk around to see if I knew them. it was just that incredible feeling of having to walk the plank to see, actually, is that somebody that I know from my community? Bear in mind, I live in East London and I'm working at the Nightingale, and what I can say to you is I know fundamentally that the outcomes were not good for a number of those people that had ended up in the Nightingale. So we can dwell on the question, is it, what's happened? Is it the exposure because we're frontline workers? What were the multifactorial things? But actually, when I attended that meeting with Simon Stevens, I think it's, and I just took an approach where it's important for us to focus on where the greatest harm is occurring. And that's us people. That is my people, my communities. So what I wanted to do is urge everybody here today as frontline workers, there is no excuse. And I'm talking to you now as a union leader, because one of the things that we face a danger of when we start to say, well, this vaccine, I don't particularly want it. It's safe, it's effective. Nobody wants to be in a position of forcing anybody to take anything or have anything imposed on them. But we have to recognize that actually what the vaccine does is prevent you from becoming sicker. Yes, so it's not necessarily stopping transmission, it's preventing you as an individual from becoming sicker. Now, I know we are going to have a forensic look at what happened through this pandemic. We all know that immediately, you see me on TV time after time, fighting the war on making sure that frontline members of staff get adequate personal protection equipment. I've been on it just recently around the masks, all of those things that we know protect us. But actually, and we know that throughout this, we knew, I could tell you what was the government was going to say next, nosocomial infections. And it was caused by the nurses, and they didn't necessarily pick it up in hospital. They picked it up in the community and they were spreading it. They didn't really get it from patients necessarily, because we know that the claims that may flow for this from industrial illness are problematic for this government. So on two fronts, really, I'd make a plea. We know that actually it's our job, or it's certainly my job, to fight for all frontline staff to get the right equipment to be able to deliver their job. It's also important for frontline staff to take care of themselves. We do know now that we have a vaccine available. And one of the things that I worry about, that if we all start saying, well, it's not for me, Gov, and we are frontline health and care staff. Now, remember, 883 of us have died to date. So there's 883 from the ONS figures out this week of health and social care frontline staff, doctors, nurses, that have actually died from COVID. And so if we start to say, we know there's an effective vaccine, but actually I don't want it, Gov, then what measure of protection are we offering ourselves? And then what argument do I have about actually protecting or getting compensation or fighting for the rights of people that aren't willing to protect themselves? I cannot tell you, as the Chief Executive General Secretary, how many fatalistic emails that we have that tell me about the suspicion of medical practice. And I say this to them, right? And I said it to somebody yesterday, I can't fight for a dead person because it doesn't make any difference. I really cannot fight the war on behalf of somebody that's died already. But what we can do, and there are lots of things to fix with the NHS, there's lots of things to fix in terms of outcomes and poor outcomes for BAME communities throughout this whole country. But actually, we need to be healthy and fighting fit to be able to take that battle. And I can't ask for Public Health England to conduct an independent review into the evidence behind infection prevention and control when we ourselves aren't taking care of ourselves. We must be confident that our masters, employers are protecting us, but we must be confident that we're doing our bit to protect ourselves. So I know that the scientists, they'll be away with it, but we are a priority group, and we're a priority group for a reason. It's really important that when we are invited to take the vaccine, we actually take it. Of course, its impact on us. We've seen COVID-19 reveal a lot about the health inequalities and wider structural disadvantage in our society. And we know that that is there. And we know that we are the group that faces that elevated risk of catching and dying from COVID-19. And we know the Public Health England report highlights the complex and multifaceted nature of the problem. But there is no denying it. We have higher levels of comorbidities. We have higher levels of environmental exposure through multi-generational households. And we know that we occupy some of those roles as key workers that put us at risk. And this virus doesn't discriminate, really, but actually it does, because if we don't start to think about protecting ourselves, it will discriminate and damage us. So it's a collective responsibility for us to do everything we can, not just for ourselves, but also protecting the people around us. It's my responsibility, it's your responsibility to act as a role model to our patients, our colleagues, our families, our neighbours, our staff. It's a collective responsibility for all of us to do that and protect those that are at risk. Now, I'm always stuck because I've got lots of mates in the NHS. When you've been around for 35 years, they say to you, Don, come down here and role model having a vaccine. But also I'm the Chief Exec and General Secretary of the Royal College of Nursing. And one of the issues with that is that they are the very same people who will say that, oh gosh, she's not 70 or 60 and she's jumped the queue. So I'm actually waiting my turn, but I am absolutely telling you today, I'll be having my vaccine. I've literally fired up my family so bad that my niece says to me, my arm's waiting. So all I'm saying to everybody, whether you're a medic, learn about the facts, bust the myths, encourage your relatives, your friends, your families, because actually there is a safe and effective vaccine around and we should be taking it. So even if you've had COVID, still take the vaccine. And I just want to say that I'm going to be around, I hope, having taken the vaccine, to support my colleagues, my friends, my communities for much longer. But actually, as I wrote to somebody that wrote a load of nonsense to me yesterday, saying with a fatalistic approach, I can't protect dead people. So let's keep fighting as a community together, but do the right thing for ourselves and for each other. Thank you.
Thank you very much. That's very helpful and fantastic. I couldn't agree more. I see some physical claps, some virtual claps. Thank you for that, Dame Kinnair. We're supposed to have the question time now, but actually lots of the questions coming through are mostly about the vaccines and how they work. So I thought it might be better if we skip to Laura, who's going to talk about the vaccines, and then we can follow through and have questions later on, if that's okay with you guys. So Laura Eghobamien, I'm going to come back to you, please. Laura is a scientist, the lead assay scientist at a pharma pharmaceuticals, and she has a wealth of experience about all the vaccines and how they work. And hopefully all the questions that you have were directed towards Laura. So Laura, please share your screen and take it away. Thank you.
Fantastic. Great, can everyone see the screen okay? Great, can you hear me okay? Fantastic. Good evening, everyone. My name is Laura Eghobamien, and just really wanted to take the opportunity to thank the organisers for inviting me to speak with you this evening. So before I begin, I'll just give a little background. So as we know, and we've heard, we are in lockdown, another lockdown, and our life has been put on hold with the coronavirus. And we have quite a plethora of people on this platform this evening. So we know we're going around with masks and our life is really not the same. And I really want to go back to how things were, where we were, partying, being able to mix with people. And I just hope we're going to be able to get this back someday. So a little background about myself. So I'm a lead assay scientist at a small biotech called Mestag Therapeutics, and they're basically involved in trying to look at the way fibroblasts are working against both oncology as well as inflammatory diseases. I'm also the founder of the Black Medical Scientific Network. This is a charity organisation which supports Black professionals in both medicine and science, and as a way of trying to educate the community on current scientific affairs. And my career really mostly spans in the biotech, and I've really been worked in developing both respiratory and oncology-based therapies. And I'm really involved in very early drug discovery and basically running more biological assays. So I've worked in a number of pharmaceutical companies. Great. So this is just an overview of what I'll be covering today. So I'm just going to give an overview of COVID and how it affects, destroys the lung. And then just to talk about how vaccine has, what we've learned through history and how that's affected our sort of perceptions. And I'll focus on the 3 main vaccines which have been approved in the UK. And then I'm just going to cover some of the myths around some of the vaccines. And I'll finally end with a summary. So as we've heard before from the first speaker, COVID-19, and this is the virus itself. And basically what we've shown as science is that we've been able to basically sequence this vaccine in the lab. And we know that spike protein is very, very important in basically the viral entry of this virus into the cell. And we also know that the lipid membrane, outer layer of the virus, is basically what causes the actual virus to be more transmissible between humans. And we know that it is an RNA encoded protein. And we know that this virus is basically can stop through soap because it's basically lippable, and basically went through washing of hands, we can basically destroy that virus. So how does it affect the lungs? So we know that through basically attracting the key area, because it's a respiratory virus, it does attack the alveolar walls. The main area that it affects is the alveoli, and basically what it does is that it destroys the surfactant of the alveoli, and you reduce gas exchange. And in doing so, you do prevent blood flowing through and preventing the whole gaseous exchange, preventing and damaging further organs there, leading to multiple organ failure. And we've also heard that this, through kind of what's been happening globally, the death rate is over 2 million. And we've also heard that recently in the UK, we've overpassed the 100,000 death rate. So how do we basically achieve herd immunity? So this is really the global aim of vaccination. And I've just got it here in this schematic here. So in the green, basically what it represents is a person who's not immunized, but it's still healthy. In yellow, this is a person who's humanized and healthy. And basically in red, this is a person who's not immunized and who's sick. So we've got 2 different scenarios. So scenario in a population where we have some of the population who's not immunized, basically what happens there is that the virus is able to spread widely across the community. So we can kind of see here is that you get more people who are infected by the virus. However, if you take a population where the people are immunized, the result is that you can contain that viral spread. So in immunization, you not only protecting yourself, you're also protecting those who are most vulnerable. So, I mean, as we've seen over time, vaccination is not really something very new. In history, we've seen it. So take, for example, we can take the influenza. So this is just a graph, but basically show here is that you see a high rate of influenza over, this is in the early 1900s. And what you can kind of see over time is that we've been able to reduce that death rate through vaccination. And it's pretty much the same thing with polio. So we can kind of see over here, you're starting with a very, very high death rate. And over time through vaccination, you are decreasing that. And then lastly, through measles, pretty much the same thing. So it is a tried and tested method that we are able to achieve immunity through vaccination. So the whole goal of vaccination, it also affects how we perceive it. So it's only going to be effective if really we are basically clued onto it as well. So this is just a graph just showing our perception. So we've been through this, we're at this pandemic now, so we've been here for about almost a year now. So March last year, when we heard about the COVID news, we were all really, really sad. And then in August last year, we had news about the vaccine. Some of us were happy at the time. And then last November, we heard the vaccine was being, it was about to be launched. And then finally, this year, the vaccine has finally been rolled out. But in a recent survey, what's been shown is that 72%, of those in the Black population have said they're not taking the vaccine. And as we've heard from the last speaker here, this is a true figure. So we just need to really remember that, we have been able to control pandemics before, like polio, MRR, and the flu, through vaccination. So if we take a closer look at the 3 main vaccines which have been approved in the UK. So we've got the Pfizer-BioNTech vaccine, we've got the AstraZeneca, as well as the Moderna, which has just recently been approved. So we know that the Pfizer and AstraZeneca vaccine, so the Pfizer vaccine is a messenger RNA, which is encapsulated in lipid nanoparticles. That's very similar to the Moderna vaccine. The AstraZeneca vaccine has been made in chips and chimpanzees. So this is using the adenovirus vector. This is basically just a vector which is carrying a virus into the cell. And the doses are really this is just based on the studies which have been shown. So all of them really require 2 doses and this is the data really from the clinical trials. And that's how the doses have been able to have come about in terms of how they're given and in terms of how long they've been given apart as well. And it's also been shown again through clinical trials is that you can detect antibody response for the Pfizer vaccine, that's 7 days, and both for the AstraZeneca and the Moderna vaccine, that's 14 days. And how effective the vaccines are, this again based on the number of people who are involved in these clinical trials. So the Pfizer claims it's 95%, 70% for the AstraZeneca, and also 95% for the Moderna. The storage facility, this is all pretty much would have been tested again through when the vaccine's been produced. So the Pfizer being the first that's just been rolled out, so that's at -70, the Moderna at -20, and AstraZeneca it can be kept in the fridge. And basically the shelf life just basically shows how stable that vaccine is over time once it's stored. So the Pfizer vaccine has the shortest shelf life. It means that basically you basically have to use it within 5 days. So if we just focus a little bit more about the science of how does vaccination work. So we know that the coronavirus is a messenger RNA virus. And basically what has been shown as science is that we've been able to sequence that. So we are able to get that genetic makeup, that template. However, we need to be able to transcribe that material for the cell to be able to see that, and that's through what's the work of the messenger RNA. So basically encoded with the vaccine is the messenger RNA, and in order for that to happen, to enter into the cell, basically that's been transcribed, and then it's then translated to a protein by the ribosomes, and then this is taken up and transported into the Golgi apparatus. So from here, the protein is further broken down. And it has to be able to present itself on the surface of the cell. And the way it does that, it can go 2 ways. It can present itself as a peptide on an MHC class 1 molecule, and it's associated with an immune cell known as the CD8 toxic T cells. And basically what happens then is that when that virus is seen, your T cells will come in and basically just mop up that virus. Another way it can also present itself is through when it goes down through in the endosome, and it goes through an MHC class 2 pathway. These are just pathway, it presents the peptide on it, and it needs CD8 T helper cells, which will also associate with a plasma cell, produce antibodies. So these are antibodies, again, when it sees the virus, is able to clear that by production of antibodies. So finally, the last part of this talk is just really just going to go through some of the myths that's been floating around associated with these vaccines. So the first myth, I'm sure a lot of people have seen this, is that the virus is, what's been said is that it contains abortus fetus. So the AstraZeneca virus has been produced in cells. And these are cells which are, these are HEX 293 cells. These are cells which are used very routinely in biotech. And they was first discovered back in the 1970s as a way of just trying to understand how adenovirus are able to cause cancer. So these would have been legally obtained at the time. And the whole reason for using these cells is that because we're trying to make a vaccine, we need a system that we are able to produce lots and lots amounts of these proteins. And what happens in this process is that you get it has to go through a whole filtration system. So it goes through a bioreactor, and therefore there's also further downstream processing and purification of that cell. So what you end up with in the final product is that you get very, very, very small traces of the cell. So there's not really that much of the cell within the vaccine itself. So another claim is that the vaccine is not safe. That the fact that it has been produced so quickly, a lot of people are scared, saying that, oh, how is it possible that, you know, it's gone through, it's not possible to be safe. So I can just also reassure you that the vaccine has gone through the same process as a new drug would go through. So right from drug discovery all the way through, right through to regulatory approval. So it would have met through all of these processes. And what's happened at the time is that normally these processes are happening independently. But because of the way this pandemic was, it was, you know, multiple people working together. So both government as well as international companies working together. And these, so both phase 1, phase 2, phase 3, they were happening pretty much in parallel at the same time. And over 1,000 documentations were looked at. So this is something that would have worked in day and night in order for it to be approved. So we have a body here known as the MHRA, who approve new drugs and vaccines, and the FDA in America. So they would have gone through all of the standard regulatory approval. So another myth is that the vaccine alters your DNA. And this first speakers already alluded to this, that, you know, our genetic DNA is within the nucleus. So because it's a messenger RNA, it's not able to, there's no way it will never come into contact with your DNA. All the messenger RNA do is basically just teaching your genetic, basically your immune system to have teaching how to make that viral protein. So there's no way it comes in contact with the DNA. And also another quotation is that the vaccine contains the mark of the beast. And this again is false. There is speculation that it contains an enzyme called luciferase. And just again, because of the name luciferase referring to Lucifer, this enzyme really, again, this is used routinely. I use this enzyme in the lab, and all it is basically is a binding mechanism, and it basically just helps your cells to be able to glow up. So you're able to see your cells in the lab, and that's all. I mean, if this luciferase was in the vaccine itself, we will all be going around glowing like light bulbs. So this is not true. So again, this here saying that the vaccine makes one infertile or impotent. Again, there is no scientific evidence to support this. There's also claims that there's a microchip that's been inserted into the vaccine. Microchip is metal, the vaccine is liquid. So again, this is just not possible for it to be to insert a microchip into the vaccine. There's also a claim that the vaccine has been developed to control or eliminate certain groups of people from our society. We are in a pandemic, you know, we've seen the numbers, so many lives have been lost. The way the vaccine has been rolled out is that high risk groups have been identified first, and they're given the vaccine first. So they've been prioritized. So it's not a way of eliminating a certain group. And there's also the final claims that the vaccine is ineffective against new strains. Again, you know, these new strains have just been come out. There are ongoing studies. We're not really sure, you know, how effective these. There are claims that these vaccines will be protected against new strains, but we need ongoing studies to be able to prove this. So there is ongoing research looking at this. And the way that I guess I see this is that we have the seasonal flu. You know, the virus does mutate. It's more likely that, you know, we will have to have a seasonal jab for coronavirus. So just to summarize, vaccination is a tried and tested concept, and we have been able to slow down, you know, disease in the past through vaccination. We can trust the science. to show, because it has been through the right regulatory approval to show that the vaccine is safe. And the fact that it will enable our immune system to make the right antibodies, and also, in addition to the T cells, to be able to fight COVID. And the fact that the more people are vaccinated, we are able to achieve herd immunity. And just final item, just that we should really, really be cautious. There is a lot of information that's floating on social media, and a lot of it has no scientific weighting. So we should really be cautious about, what we're reading, where we're getting it from. People forwarding us things on WhatsApp. Really question what it is they're forwarding you, and just try and ask basically an expert in the field. We have a great opportunity to discuss this evening, to get the fact information as opposed to a fictional information. Thank you very much. That's it. Thank you very much for your time. I'll stop sharing my slides there.
Thank you so much, Laura. Again, that contained a lot of information, and I can see the chat box is getting away with many questions. What we'll do, we've got Dr. Ikpoh and Bishop Dorgu left to go. I've made a list of questions, some that we've tried to answer in the chat, and others which I'll put to the panelists at the end. So if we can welcome Dr. Margaret Ikpoh, who's a GP and has been leading on the vaccination in the community, and just to talk about the challenges and successes that you've had so far. I shall share your screen for you if you can.
Thanks, Mike. Can you hear me okay?
Yes, we can.
Okay. So good evening, everyone. Whilst Mike's getting the presentation ready, my name's Margaret. I'm a GP partner in the Northeast, Far East, otherwise known as Hull. And I've been here for about 10 years, but I was born in originally in London. I've got many hats on, but predominantly I'm a GP and I work 4 days a week as a GP. So as Mike has alluded to, I'm just going to have a bit of a chat, because Laura, I think, has done half the work for me on what we're currently doing from a primary care, from a GP perspective, if that's okay, and discuss some of the successes we've had and challenges as well. Oh, thank you for that. So I'm not very, although I am from a science background, it's not going to be very scientific. I'm going to take on a bit of a personal journey of mine. And also because it's very late in the day, I think I work probably better with pictures. So about a year ago in February, I took my family with a group of friends to Nigeria. My dad's from Nigeria. And this was the picture that greeted us at the airport. And I remember just being stunned and saying to my husband, I said, is there another Ebola outbreak? Have I missed something? And one of the ground staff said, no, madam, there's something happening in a city called Wuhan, which I think not many of us had heard of before. And also with what's happening in Italy and Spain, we've been through Ebola and we're not taking any chances. So a week later, when we got back to the UK through a very different airport, I must say, we were having dinner around a table with some family and friends. The majority were healthcare professionals. And I will never forget the comment that was made, because at that point in time, we had our first 2 cases of COVID that presented in York. And one of these poor patients had to come to the infectious diseases unit in Hull. And I said, I am really worried about this, because I think this could be something bigger than any of us have seen in our lifetime. And the response from quite a few of my colleagues was, COVID does not affect Black people. And that was said because at the time they were looking at particular areas in Africa, looking at America, and just coming to that conclusion, unfortunately. Next slide, please. So what are we doing in primary care? Because now we know not only does it affect Black people, but like Professor Kinnair has alluded to, we are disproportionately affected by this virus. So we all expected a vaccine, and I know there's been a lot of chat in the group that, before this development of vaccine, it took roughly about 4 years to develop a vaccine. The reason why this has happened so quickly, because none of us here, and it's really, I'm really empowered by the fact and really humbled by the fact that so many of you have joined us today. Some of you are convinced, some of you are not convinced, and that's absolutely okay. But the fact that you're here means something, that you want to gain more information. So many platforms were working at various times during this pandemic to achieve a common goal. mRNA vaccines have in fact been around for at least 30 years. But the pandemic has just literally catalyzed the efforts, because for one point in our time, we all had a common enemy, as it were, which was this virus, which was causing not just, it wasn't a UK problem, it wasn't an Italy problem, it wasn't a China problem. This is a global problem with a devastating impact, not just on our health, but as you can see, on the economy around us. So in primary care and GP, we started the first wave on the 14th of December. The hospitals, we're working parallel with them, started a week earlier, but 75%, at least 75% of the vaccination program is being delivered through primary care. And at the beginning of this week, we achieved a remarkable feat of at least having 7.7 million people, as Chinenye mentioned early on, being vaccinated already. We're currently arranged in primary care networks, and what that is, the primary care networks are basically a group of general practices that come together for common good and to deliver services to our community, and the vaccination program is one of them. So for me, one of the main successes of this has just been the sense of community. Our volunteers have really stepped up, from just retired healthcare professionals, people who just at home who want to chip in, our medical students, whether it's marshalling, vaccinating, data admin, everyone stepped up to the plate to try and help us solve this problem. Next slide, please. So we have a committee who decides who's going to get the vaccine, called the Joint Committee of Vaccination and Immunisation. So at the moment, the strongest predictor of mortality is age. So we're all being grouped into 9 groups, starting with those over 80 and our care home residents and frontline workers. There has been some debate as to whether Black and Asian minority ethnic people should have been prioritised, and those debates are still ongoing. However, it's hoped that with the successive rollout of the vaccine, and once we've all been offered it, that at least by autumn of this year, that everyone, hopefully, who wants to take up the vaccine has had a jab in their arm. Thank you very much. Next slide, please. So what do you expect? When your time comes, you will get a phone call, a text, or an email to invite you to the practice or a vaccination hub. If you are going to a vaccination hub, don't forget your reference number that you're given, because you'll need that when you present to the vaccination hub. And when you get there, there'll be a checklist of questions, including screening for COVID positivity or symptoms. So you can't have the vaccine if you've tested positive for 4 weeks. You have to wait 4 weeks until you've had a positive test or symptoms before you can have the vaccine. And also they'll check for side effects that you've had to different drugs before. Now, the majority of us will not have any major allergies to this vaccine. You will recall, however, there were 2 healthcare professionals that did. And as a result of that, the Pfizer vaccine, if you are having this Pfizer vaccine, there is an observational period of at least 15 minutes before you are allowed to leave the building. But even if that does happen, there are well-trained staff on site who are able to deal with any severe allergic reactions. If you want to know exactly what's in each of the approved vaccines, if you go to nhs.uk, click on the tab for the coronavirus vaccination, you'll be taken to each of the three vaccines that have been approved. There's another one coming from France in autumn. And on that site, you'll be able to see the exact ingredients that are in there. So as I explained to my mum yesterday, and Laura's already said this, there's no animal pork, there's no pork, there's no animal products, there's no fetal products, there are no microchips, you know, she's concerned about being tracked. And I said, well, you know, your mobile phone and your bank cards do a good job of tracking you in the first place. And then you'll be told of what to expect after you get the vaccine. Next slide, please. So what is the truth? And there is a lot of information out there. And when you're in lockdown, I can understand that we are exposed to a lot, including, like I've alluded to, my parents. And I myself, a slight disclaimer here, was quite doubtful when I heard that the vaccine was ready. And the common argument I get, particularly from my family, is, well, we're just waiting. We want to wait. And waiting's okay. But like I've said before, whilst you're waiting, the virus is mutating. That's not to scare anybody. I'm not trying to scaremonger, like my mum said to me yesterday. That's just a simple fact. Next slide, please. There are reasons. Vaccine hesitancy goes back a long way. We've had it before with the childhood vaccines. I can remember the hesitancy with the MMR. And that's for various reasons. It could be specific to the vaccine because, like I said, people are worried with regards to what's in them. It could be for very individualistic reasons as well. People are worried about their own health. You know, I'm having chemo, I've got sickle cell. There's a whole load of reasons why people are worried about that. And if that is the case, I just encourage you to speak to your healthcare professional and establish your own risk, because everybody's different. And that could be contextual. And Laura's already alluded to the reasons, particularly with regards to religion, with regards to that. Next slide, please. So why did I have some hesitancy myself? Well, the systemic and institutional racism that we all face is well documented. I won't go through each of these pictures. And some of you might recall that we had even 2 French doctors who suggested testing a vaccine for TB in Africa. And that even prompted the Director General from the WHO to say, Africa is not a testing ground. But it's really important that we put things into context here. Next slide, please. Dr. Dorgu talked about the psychological impact on particularly young people. And that's one of the 3 reasons why I changed my mind. Next slide, please. So it's the same pandemic, but a different impact. And my daughter, last year, I think we were a few months into a lockdown, and she said to me, Mummy, why is it that everyone on my TV screen looks like you and Daddy? Because we're both in the NHS. And her absolute anxiety was apparent at that time. So that was the first reason. The second reason was that we had someone very close to us in our family that died in London, 45, and she left behind a young family. So then it became, we call it COVID came home, because it became very real. Next slide, please. And of course, the third reason is because, like I said, one of the successes has been our volunteer and community response to the vaccine, in particularly distributing it. And I think we're going to need that equal response from our community to protect ourselves. I can have the vaccine, that's great, and the ones of people around me will have the vaccine. But unless we all step up to the plate, it's a community effort. It's not just about personal protection anymore. It's about protecting all of us. Next slide, please. So all I ask people to do, because this is, like I said to my mum yesterday, this is not by force. Everyone has the free will to make an informed decision about your well-being and your health. Health is wealth. But all I'm asking is, when you get that WhatsApp message or that message, and just check where it's coming from, who's forwarded to you, where they come from, and why. Check the source. It's very easy to do when you get a message and you're not sure about it, but use trusted sources. Next slide, please. So this is the last slide. I'm sorry, it's very quick, but we had the UN Secretary General, when we had our City of Culture here 3 years ago, and he said just before he died that knowledge is power and information is liberating, and education is the premise of progress in every society, in every family. And I would like, if I dare, add to that and say knowledge, information, education, but health, because your health is your wealth, and that's what's going to get us through this. Thank you to all of you for giving up your free time, particularly the panelists, and especially to Mansag for this forum to allow us to share our knowledge. Thank you.
Thank you very, very much for sharing your experiences and making it personal, because I think that's really important, that people know that COVID is not the other. It doesn't affect everybody but you. If it's not around you, it's around your family members. And as healthcare workers, we've seen this very, very close up, and we know what the impact is. And just to bring our last panelist up to speak, I'd like to welcome Bishop Dorgu, who's the Bishop of Woolwich, who he was medically trained. He doesn't practice anymore, but hopefully he will answer some of the questions you have from a sort of religious perspective. So Bishop Dorgu, please unmute yourself, and the floor is yours. You're still muted. You're still muted, Bishop Dorgu. There you go.
Oh, it's got to unmute me. Yeah. Hello, good evening, everybody. Thank you, Mike, and thank you all so much for what I would describe as a brilliant evening of scientific expose. I want to give credit to all the speakers tonight. I mean, Dr. Mike here might said I'm no longer in practice. Who said that? Once a doctor, always a doctor. doctors never stop practicing. You'll be surprised. I'm still giving prescriptions. Don't tell anybody that, okay? So tonight, I just want to talk about what I believe is the background to a lot of the myths and hesitancy we've seen in our Black community. Because as you know, you very rarely find a Black man who is an atheist. And as the professor said, it is our community. And having been around this business for over 30 years, I can tell you that in this last week, my wife and I have been very shaken because we've lost 3 people that we know to COVID, all BAME people. 3 people that, and the youngest was in his 50s. He's left a wife and 2 children. So tonight, what am I talking about? I'm talking about religion, spirituality, and vaccines. I can assure you that the scripture says that all scripture is given by inspiration of God and is profitable for training, for reproof, correction, for instruction in righteousness, so that the man or woman of God may be perfect, thoroughly furnished unto all good works. And I can assure you from Genesis to Revelation, the scripture says nothing about vaccines at all. Just as it says nothing about GP surgery or GP practice. But I can assure you that there are 2 key references in scriptures in the Old Testament, before we come to the New Testament, where reference is made to medical cures and medical panaceas in relation to epidemic conditions. For example, in Numbers chapter 21, some of you may be familiar with this. After the children of Israel, in their journey from Egypt to the promised land, murmured against God and complained about the things that he hadn't done for them, the Lord sent venomous snakes amongst them. As the snakes started to bite them, they died of the effect of the venom. But Moses went and prayed to God, and God said to him, okay, Moses, make a brazen serpent, put it on a stick, and raise up the stick. And anyone who is bitten by these poison venomous snakes, if they look up to that serpent that you raised up, they will be saved from the effects of the venom. So Moses did that, and as many as looked up to that brazen serpent on the stick that was raised was saved from the effect of the bite, of the snake bites. And today, you know, that snake that was lifted up in the wilderness has been taken by New Testament commentators and New Testament theologians as a typology of Jesus Christ being raised on the cross to die for the salvation of all humanity. But I can tell you one of the interesting thing, that snake, that serpent that was raised on the stick, today is the symbol of modern medicine all over the world. So whenever you look at the medicine, the symbol of the NHS, the serpent on the stick, that's where it comes from. So that was the first case we come about in Numbers chapter 21. Secondly, in Jeremiah chapter 8, the people of Israel were going through an epidemic as a result of their disobedience to God. And the Lord spoke to them that in order to recover from their pestilence, they had to use the balm in Gilead, which the Lord had given to them to use as a panacea, as a remedy to the situation. So that was the second reference medically. And of course, in Jesus' ministry, Jesus in the New Testament spoke about the fact that they that are not whole have need for a physician. And he put it the other way. They that are not whole have need physician, because they that are whole have no need for a physician. I say to my friends today that the scripture does not contradict modern medicine. So if you go to a church where they tell you not to use medicines, please think about it. Think about it, go to the scriptures and look at it again. The medical school where I was trained had a motto that said, we care, God heals. God is the one who gives us all healing. You've heard of all the science that's been spoken to us about this evening. All the wisdom is from God. In fact, the scripture says that in the last days, wisdom shall increase. So what are we talking about? Lots of pastors, out of ignorance, have fueled the myth and the conspiracy theory that this mark of the beast. But I tell you, they've read the Bible out of context. because the Bible speaks in Revelations and also in 2 Thessalonians about the coming of the Antichrist. It is going to be an economic system, and it's going to have to do with commerce and trade and livelihood. And it's going to be a mark on the right hand or on the forehead. And so a friend of mine said jokingly that when you go for your vaccine, you can tell them to put it on your left arm, so that it won't be on your right arm, because it means that it cannot qualify to be the mark of the beast, because it has to be on the right. So I tell you, out of ignorance, so many pastors, right-wing pastors, are even saying that the COVID vaccine is a myth. Like Donald Trump, they're saying it's a China hoax. It's a hoax from China. It's nothing serious. But I've just told you, 3 of our friends died last week. And in Britain, 100,000 people have died. But we're not talking of cases. Like Margaret said, COVID has come near home. Because when it happens to someone that you know, then you're no longer thinking about it as cases out there. It is your friend, it's your relative. So the Christian religion teaches us in our spirituality to give respect to all those in authority over us in government, because God ordains our governments for civility, for order, for law, for the effectiveness of the system, so that we may all live peaceably under God's authority. And today, I ask myself the question, how have we become so rebellious as a nation of people? We don't have respect for authority. We don't have respect for people who care about us so much, because we think we know more than ourselves. So I beg you, my friends, Jesus said, love your neighbor as yourself. And like all the different speakers have said this evening, if you're not going to take the vaccine for your own self, take it for the sake of your family and your friends. Because as you have heard, if you don't take it, then you are not immune to it. If you're not immune to it, then you become a carrier of it. And if you're a carrier of it, then you can give it to other people. And if you can give it to other people, they can become fatal to them. Just imagine if you were responsible for the death of your closest friend because you refused to take the vaccine for some stupid reasons. So what I say, my friends, is that today, God calls us to be sensible and wise. The scripture says that we should be as wise as serpents and harmless as doves. And I say to you, as someone with a background in medicine, that modern science is a gift from God, because the scripture says that in the last days, wisdom shall increase and we shall overcome all sorts of things. And you can see it happening before us. So I beg you, do unto other people as you want them to do to you. Jesus said, love your neighbor as yourself. For the love of neighbor, take the vaccine for yourself. Last Saturday morning, I was very, very honored and very grateful to God that I had the opportunity to get my vaccine, because you will not believe it, I'm over 60 years old. So I didn't jump the queue. I was invited to get it, and I took the vaccine, and I'm very proud to say that God has been so faithful. I'm still here. My DNA has not been copied. I have not been marked by Bill Gates. I am thanking God and waiting for the second dose so that I will not be a spreader of the virus. And by the grace of God, I care so much about my neighbor, as Jesus said. I love them so much, I do not want to be responsible for the fatality that affects them. Thank you very much for listening. And God bless you as you take the vaccine.
Thank you so much, Bishop. Thank you very, very much. I can see some comments in the chat box saying some of the teachings are very similar to Islam. And it's a shame we couldn't get an imam or a different spiritual leader here today. But I know that in the community, these messages are being shared. And if people have questions, please reach out to your spiritual leader, to your community leader, to your GP, a friend of yours who's a healthcare professional. And I'm sure we'll all be more than happy to answer those questions in whatever way we can. Now we're going to open to question session. We've got about 25 minutes to hopefully answer some of the questions. And we've got some which came by email previously, quite a few of those. So we'll try our best to cover as much as we can. So I'll start off with some of the questions, if that's okay. So one person said, the global community is working on curing and preventing COVID-19. What causes COVID-19? I propose we start applying our efforts and energy to addressing the root causes and not its effects, i.e. looking for a cure when one falls sick. I suppose the short answer to that is you're correct. Prevention is always better than cure. And the aim is to try and improve our health to prevent, conditions getting worse. However, it is here. It has come home. We've had more than 100,000 people die. And to prevent that getting worse, it's important that we, as well as try to find a cure or minimize its effects, focus on prevention. And going forward, I think people have raised the questions of natural immunity. I will put that to some of our speakers. They've also talked about why we're not recommending things like vitamin D. By all means, as healthcare professionals, we always recommend a healthy lifestyle, so diet, exercise, making sure you're taking care of yourself, losing weight. But things like vitamin D, vitamin C, zinc, take them, to boost your immune system. That doesn't stop you getting COVID. And if you do get COVID, that's not necessarily going to spare your life. So it's just to let you know that these things are not, one or the other. You can do things together. So first question, please, to throw to Dr. Chinenye Ilozue. So the question says, how effective do we know the Pfizer vaccine will be, which is based on a viral spike, considering there is supposedly no data of the long-term immunity of the current mRNA vaccine and the impact that will have on a new variant? So I'll let Dr. Ilozue answer that, and maybe Laura can chime in on that as well. So Dr. Ilozue, if you go first, please.
Sure, that's a really good question. And obviously it's crucial in terms of thinking about, Hello, can you hear me?
Yes, we can hear you.
Okay, sorry, I thought he said he couldn't hear me. It's a really good question, and it's crucial in terms of thinking about our protection moving forward. And the short answer is, essentially, we don't know in terms of long-term protective antibodies protection in terms of the vaccine. We know that it's effective. We know that it prevents severe disease. We know that it prevents disease in the first place. And we know that it definitely prevents severe disease. So it prevents people being hospitalized, and it prevents people being admitted to intensive care and needing ventilation for that significant respiratory distress caused by the COVID infection. In terms of how long it lasts, the thought is, essentially, long-term in terms of how many months and how many years, or whether we're going to be needing revaccination. All of this is being looked at. The fact that the vaccines have been approved now by the MHRA, the fact that, it's been rolled out does not mean that the work has stopped. In fact, the work is probably ongoing more than it was through the sort of phase 1, 2, 3 of the trials. So, people are still recruited to these studies, and they're still following up in terms of antibodies, and they're still following up in terms of antibody response and also infections, so that we know essentially how long protection lasts, and then we're able to roll out in terms of when revaccination will be required. But for now, in the short term, in terms of coming out of the pandemic, the vaccination is fundamental. And we know, just a point about natural immunity after natural infection as opposed to vaccination, there's been recent data to show that it's at least up to 5 months, potentially more, but certainly we know up to 5 months for natural infection. And the vaccine is likely to be longer than that.
Laura, if you want to chime in on that, that would be very helpful.
Yeah, just add to that. I mean, I think, Dr. Tuesday did really well in there. So in addition to that, we know that our long-term immunity is our adaptive immunity, and that's something that's followed over time throughout the course of our lives. And also, in addition to that, it's not with the antibodies that we produce. We also have a spectrum that some of them are neutralizing. So we don't know how many of those antibodies are actually neutralizing antibodies, and that's a study that needs to be ongoing. And also, it's not just the antibodies, it's also our T cells as well. So our CD8 T cells, which are very effective in trying to basically the way that they produce porphyrins and granzymes to basically eliminate this virus. So there are additional studies which needs to be done, and that's kind of ongoing as well. So the long-term effect, we have to kind of take everything into context, so just the antibodies as well as the T cells as well, and other immune cells which are also involved.
Okay, thank you for that. Another question, which I'll hopefully put to Dr. Daniel Osigbe, says, yesterday we recorded 100,000 COVID deaths. How do we know how many people have actually died of COVID rather than for another reason? Also, what about the number of people who have died of flu during this period? Some people believe some of these COVID numbers include the numbers of people who have died from flu, but it's been recorded as COVID. Daniel Sigbe, please. Daniel, are you here?
Yes, I can hear. And so I think the host wasn't letting me on mute for a while.
There you are.
Well, thank you for that question. And thank you for all the panelists for the wonderful presentations. With regards to kind of the number of deaths from COVID, I'm not sure if I'm the best placed person to answer it, but I'll answer it as best as I can. So I think, yes, I think the figures are as accurate as we have. What I would say is looking at basically what we call the excess mortality. So in a year, we have about less than 4,000 people die from flu. Now we've had over 100,000 people die. This is not the flu. This is not a common cold or anything of that sort. So when we look at the figures, these people have got a diagnosis of COVID and they've all died. And we look at it mortality compared to other times when we didn't have COVID, and it's a lot more. So I think we can be quite confident that we're headed in the right direction. But I also think there is also underreporting of COVID as well. Not everyone comes forward. As a GP, I've seen patients that have died at home and they've just been found by an ambulance crew. So that would be my answer. If anyone else has got anything else to add, feel free to add it. I think you're still muted, Mike.
Yeah, Chinenye, do you want to add something to that? Thank you so much, Daniel. You're on mute, Chinenye.
Yeah, it's just, can you hear me? It's just to reiterate, absolutely, Daniel's completely right. This is not the flu. We're here seeing COVID every single day. We're working in hospitals throughout the country, throughout the world. This is not the flu. We are all used to what flu does, and this is not it. Trust us, the hospitals are not empty, they are overflowing. And certainly excess mortality, it's absolutely evident that this has been a massive hit, as is, similar to the Spanish flu in 1918.
Lovely, thank you so much. I've got another question which says, I have what is termed as allergic asthma and being prescribed cetirizine and Symbicort. My concern is the likelihood of a reaction on taking this vaccine. What trial tests have been done to reassure people with strong allergies? I think I might put that to Dr. Margaret Ikpoh, please, if possible.
So allergic asthma is basically you have a condition that affects your lungs because there's an allergen, so something that you're reacting to, whether that's pollen, an animal dander, or grass. The way I put it quite simply is, if your condition requires you to carry what we call an EpiPen or Enerade, so these devices are devices for people who have severe anaphylactic reactions. If you have to carry one of these devices around, you will need to speak to your GP about the vaccine, because you'd have to, if you're going to be administered the vaccine, it would have to be in what we call a controlled environment, and you would have to be observed for a period of time. And even if you do carry it, it's only if you're actually allergic to one of the ingredients in the vaccine. Otherwise, if you are on a steroid inhaler or antihistamines like cetirizine or loratadine or Piriton, then there should be no reason why you can't have the vaccine.
Lovely, thank you so much. And I'll do one more question, and then after this, maybe Chris, if you can help take a question from the chat box, please. So another question I'll put this one to the Bishop this time. It says, could you justify why we should continue to believe the activities of the WHO when it is alleged that, to a large extent, it's funded by people and organizations that are believed to be architects of the fulfillment of the world order as prophesied in the biblical writings?
Thank you so much. What a lovely question. As I said earlier on in my presentation, the scripture is in Romans chapter 13 that all authority is ordained by God. And one of the things I said about the Old Testament was that Moses had the authority to raise the serpent on the brazen serpent on the stick. And all those who looked at it in respect to authority, in respect to the word of command that they've been given, they saw it and they had an antidote to the poisonous effect of the venomous snakes. So today we can equate the WHO as an organization that's been put together to protect our world in terms of health issues and socioeconomic issues. Now, for years, the WHO existed as a very positive contributor to the general well-being of our world in terms of the nations of our world. For example, the WHO is arguing as we speak now for nations that cannot afford to pay for the vaccine, to have vaccines paid for by the richer nations so that the poorer nations can benefit from it. WHO does all sorts of things with World Health, with health education and health control and primary health care all over the world. I'm saying this as a doctor myself. So today, the WHO we've trusted all these years, we're suddenly listening to conspiracy theorists that are saying that the WHO is funded by these people that are trying to control the world with their money. That is an absolute fallacy. In fact, if you went to New York today to the WHO, they will tell you how badly they are in need of money. And one of the number one debtors of the WHO is the United States, because they don't always pay their bills. So the WHO is struggling with their funding as well. Don't let anybody tell you that the world's richest people are funding the WHO. That is a blatant lie. So the WHO is not there to meet anybody's needs, but has been set up by nations all over the world who have representatives that sit on the WHO. In fact, it would take a huge conspiracy of the entire world for the WHO bought out by this so-called Illuminati and the people that are controlling the wealth of the world in order to punish Black people. So I want to debunk that lie. So today we can trust the WHO because they are set up for the good and the well-being of the general health of our world. And if I ask you to ask those people who have told you that to tell us what alternatives they've got, I'll be very pleased to hear what they have to say.
Thank you so much for that. A question to Dr. Ikpoh, please. It says, why is Corona affecting adults only and not so much children in terms of how unwell they get?
So, fact, Corona does affect children. I have the unfortunate task of processing positive results for children every day. Fact, children who do get COVID, usually it does result in a mild form of illness. The majority of them are actually asymptomatic, so they don't have symptoms, but they can still test positive and transmit the disease. That's fact. Why children tend to not have the severe consequences of COVID as adults is still being researched, because we don't know whether it's because they don't travel as much. There was some mention about ACE2 receptors that Chinenye alluded to. So there's a disparity of those receptors in the children. So we don't know. But children, the youngest I've seen is 4 weeks of age. They do get COVID. I'm sorry, but they do.
Thank you. I'm not sure if Dame Kinnair is still here, but if she is, I've got a question for you, which is, to what extent, a slightly difficult question, to what extent have structural inequalities and racism led to our plight?
Well, I mean, that's a really interesting question, isn't it? Because, a lot of what we suffer from is structural racism and historical issues, whether you think back to Tuskegee. There are so many things around, as one of the panelists mentioned, that we can point to. I'm just curious, I can just, following up from Margaret, my grandson's 11 months and he had COVID. So he was COVID positive and managed to no ill effects for himself. But going on to the extent of structural racism, it is pervasive in our society. We've seen it from Floyd right the way through historical issues. And the point I'm making, and I'm concerned about in the chat, because clearly some people haven't suffered or seen relatives die, or it's not come home to you. But this disease is killing. As far as I'm aware, racism we suffer from that. But actually, in this context, we're talking about COVID-19 and the impact it's having on our community. So I'd like to just point out that if it's not impacting on you and you haven't seen it, talk to someone who has, because if you've lost a friend, a relative, a fellow nurse, a colleague, we are all as frontline health workers seeing the impact of this. Some of the historical things will be there for a while more, and we've got to fight against them. We've all seen it this year with the impact of George Floyd's death, and we still have to rage against them. But I just want to say, this is in the here and now, it's real. So if you haven't seen it, if it's not affecting you, talk to someone it has, and then let's then, you know, at least keep ourselves alive so that we can actually deal with some of the historical and structural issues in terms of outcomes for our communities.
Thank you so much.
Could I just add something, Mike?
Of course.
Just add to what Prof has said. Thank you very much, Prof, for what you've said. I just want to say that part of the response we're having from the government is they are responding to the effects of the Black Lives Movement protests. Because if Black people have been so disproportionately affected and they want to do something about it, then they're encouraging Black people to take the vaccines so that we will not be disproportionately having on a long-term basis the fatal outcomes that we've already experienced. So I think it's a response to what the social campaign has been about. And for some of us, it's a surprise. And it's generated suspicion amongst us because we are not used to being paid attention to. And now that we're being paid attention to as a community, some of us are finding that suspicious in itself. And like Prof said, when it comes home, like Margaret said as well, when COVID comes home and affects somebody that you know, a relative or a friend, then you know it's real. It's not just a joke. It's not just cases out there. And I say this as a bishop, because in my diocese, we're encouraging our BAME people to stand up to the line. I have taken my COVID, we put it on our diocesan website to see that I'm not just talking about it, I have taken the vaccine myself.
Thank you so much for that. I'm just going to address something that's been raised in the chat, which is if you have underlying medical problems and you have COVID and you pass away, COVID will be put in your death certificate. If you have ever filled in a death certificate, you would know that most of your conditions are on there. So you put in what's directly caused your death, what led to that thing that directly caused your death, and any other underlying conditions. People with diabetes and blood pressure, or even COPD, so respiratory conditions, which may well in the long run have contributed to the death. If you get COVID and COVID speeds that up, unfortunately, COVID has to go on your death certificate because it contributed. Having diabetes does not mean you are going to die tomorrow. COVID can make that happen. So we have to acknowledge that. So I hope I've addressed that in the box. Just a question again, I'd like to put this to Chinenye, please. Actually, I put it to Laura, sorry. It says, if brown-skinned people are being affected more by this virus in the West, then why has Africa has the least cases?
Okay. I don't believe Africa has the least cases. I think it's just underreporting and not enough testing.
Absolutely.
It's the same case for vitamin D as well. So yeah, I just think we're just not testing enough. That's basically what it is. So it's under testing that's kind of resulting to that.
Yeah. Yeah, I mean, I completely agree with that. I think certainly in parts of Nigeria and in parts of Africa where there's significant poverty, you can't, people are not willing to self-isolate or close their businesses because in reality, hunger kills quicker than COVID. And so it's definitely significantly under-tested, it's definitely significantly under-reported. I've had family members who died of malaria despite having breathing issues and clearly having COVID symptoms. So it's a difficult one, and even you can't prove in hindsight. As Prof says, you can't fight for dead people. I can't go back and check if they had COVID. But I think the numbers are difficult to trust.
And there's also the shame factor as well.
Absolutely, stigma is a huge thing.
Just like HIV was.
Yeah.
There's also the cultural stigma that's associated with COVID. And people, when family members have it, they won't say it was COVID. It's not matter, It's more acceptable to say malaria to say COVID.
So we have a rather long question, which I might split up and put to different people. It says, it has been reported by eminent scientists around the world that the 3 vaccines are not vaccines. They are synthetic materials with no connection to the primary source. Laura, that one's to you. Quickly, please. We have 5 minutes and 9 parts to this question.
So yeah, that's not true. So I've already explained to you that they know that we've sequenced the viral protein, and that viral protein has been able to decode it through messenger RNA. So it's, you know.
Good. It says the virus has not been specifically isolated in the lab, and this is contrary to what has been reported. Again, Laura, that puts to you.
Again, we've just said that we've been able to sequence the protein from people who've had COVID, so we've got the genetic material sequenced, and that's how we've been able to make the virus. So that DNA has been sequenced.
Okay. It says our DNA is different from Europeans. Can you prove that radiation from 5G is not causing current symptoms being reported? And once again, numerous eminent scientists around the world report that it actually causes alterations in the electromagnetic field, and that radiation has triggered current events. These scientists have a vast wealth of experience. Chinenye, I'll give that one to you.
I'm not quite sure where to start with that one, but number one, biologically, our DNA is not different. We're human beings, and DNA is made up of the same building blocks throughout humanity. So that is false, number one. And therefore, this thought that, you know, we are affected differently because we are genetically different is biologically false. So I'll just start with that. And the 5G thing, I'm not even going to address it because it's one of the ridiculous misinformations that have been circulated just too much. So yeah.
Thank you. Being advised to take this vaccine is dangerous when vaccines take up to 10 years to be validated. I think we've gone through that and explained why this has happened so quickly. And it says doctors and nurses in America are refusing to take the vaccine. I can answer that one. I think a lot of doctors and nurses and healthcare staff everywhere have thoughts about taking vaccines. It's a personal decision. You are strongly encouraged to take it. We hear your questions, we hear your worries, and the aim is to hopefully share knowledge and talk it through. And if you have alternative theories, then please bring it forward and let's discuss it and let's find proof. Good. We'll have a couple more questions and then we'll round up. So someone said, I read some articles on the vaccine, on vaccine-induced antibody response. This coupled with various staff I know going on to have the vaccine, going on to have COVID following vaccines, leaves me concerned. Given that we have more or less been constantly exposed to vaccines since the beginning, it seems more than coincidental to develop symptoms following vaccine. I've had my first jab, but it's making me not want to have the second. This is not a question, but maybe something we can address. Chinenye, can I pass that to you, please?
Yeah, sure. First of all, just to say, it's a big misconception. You cannot get COVID from any of these vaccines. They do not contain the virus. They do not contain live virus. They do not contain whole virus. They either contain RNA, which encourages your cells to produce the spike protein, and that RNA gets degraded within days, so it's no longer in your body, or it contains the viral vector of the adenovirus. It's not a live virus, it's not COVID, so it's impossible. We know that from Pfizer and AstraZeneca that vaccination, we know that it doesn't necessarily prevent infection completely, and this is a very difficult thing. As healthcare professionals and scientists, we're quite used to risk and benefit, weighing up the risk, the benefit, it might be this, it might be that, more studies needed. However, when we try and convey that sort of messaging to the general public, it's what people want is certainty, right? They want the certainty that I've got the vaccine, I'm definitely protected, I can take my mask off, I can go. That is not the case. Certainly after the first dose, you are still at risk of being infected with COVID. And we've seen that, certainly because we know the first dose doesn't provide complete protection. And as we know, it's not protection from infection, it's from severe disease. So it's the most important thing to recognize, and it will reduce transmission in the community. And this is why it's so important to get vaccinated. So essentially, we know that it's important, as I say, it's about doing your research. And when it comes down to the effects of sort of the vaccine itself, you cannot get COVID from the vaccine because it doesn't contain any live virus.
Thank you very much. And a question to Daniel, please. Dr. Osigbe, it says, if the vaccine only instructs the body to produce lots of antibodies, then why is mankind's natural immune system ability to produce own antibodies being undermined, knowing well that the majority of people are and can survive this virus? You're on mute, Daniel.
And while Daniel figures it out, that will be the last question. And after this, we'll just round off. I'll just get a final word from everybody.
Yes.
So Laura, I'll go with you first. As soon as Daniel, are you ready now?
Still on mute.
Okay, don't worry. I'll sort you out. Laura, a final word,
please, Laura.
Final word on the question or final word on?
Just the general comments.
Now I'm in an elevator with you. You only have 30 seconds to tell me something about the virus. Oh, sorry, about the vaccine. There you go.
Sorry, I'm really speechless. So yeah, sorry, I'm getting a bit confused about if it's for the question or, but yeah, I believe we've already spoken about, our own natural immunity, that it's not enough, that we need, the vaccine to be able to boost that. And there are not just antibodies, but there's also T cells that's going on. So it's not just only your natural immunity that we're focusing on. So this is enhancing your immunity with the vaccine.
Thank you very much. Margaret, your final word.
30 seconds to address the speed issue. 1,800 GP practices for the first time ever this year trialled azithromycin, hydroxychloroquine, and doxycycline. We were very quickly, this has never happened before, we were able to get to actually, in a very short space of time, dispel the fact and say, well, actually, these drugs don't really do much for COVID. And now we're trialing a budesonide inhaler, a steroid inhaler. So this has never happened before, and this is just done on a national scale. So the argument about it taking too quickly on a global scale, let's just think about this, guys. Please protect yourselves.
Thank you very much. Chinenye, for the person who just said he or she is undecided, your final word.
So the final word is that the risk of COVID is definitely higher than your risk from the vaccine. That's the final word. I've had my vaccine. I've had 2 doses. I don't have 2 heads. It's all been good. And yeah, we are just grateful that we have this chance of getting out of this nightmare dystopian scenario that we're all in.
Thank you. Donna, your final word for that person who says he or she is very unlikely to take this vaccine.
People, we have 100,000 people dead. That's not a joke. And if your natural immunity was working for everybody, then we wouldn't have 100,000 people dead. So I just point you to that fact. And I'd say we can all take a chance, but you may not be a lucky one.
Mosun, thank you very much. Your final word.
Have the vaccine, and in the past week, I know at least half a dozen people who have passed away as a result of COVID. These are names, not numbers.
Thank you. Daniel Osigwe, your final word or your answer?
And your answer.
So thank you. So just back to that question, I think I'll answer it first of all from a non-scientific point of view. I think what I would say to that, we're not bypassing people's community. I think the important thing as doctors, first of all, is that every life matters, that we're always trying to save everyone, whether it's a 88-year-old granny or granddad. And I think that's the important thing. We cannot be selfish about this. And I would say that very strongly. We can't be selfish about this. We can't feel that all our grandparents can pass away. And I think that's what the vaccination does. It gives people immunity without having to go through the process of having the disease. And a lot of older people or people with comorbidities, if they go through the disease, might die from it. And that's what we're finding. And I think that's the whole point of the vaccination. And I think it's just referring to the fact that also, even with natural immunity, people respond to it differently. But the vaccines work in such a way that they can hopefully give greater immunity than natural immunity. My final words to say is that actually, I think we're making things a lot more complicated than it is. And I think we need to focus our energy in the right place. It's not a conspiracy, it's here, and we need to deal with it. And we need to do this together because we're all in this together.
And Bishop Dorgu, your final word.
Oh yes, just thank you so much. As I said to you earlier on, starting from the Old Testament, God gave the children of Israel an antidote to the venomous effect of the snakes that he sent, that was destroying them in judgment. So God is completely on the side of doctors as they prepare antidotes for us. Jesus said, they that are whole have no need for a physician. So because we're not whole, we have need for physicians who are honorably doing their great for us, their great job towards keeping us healthy. And thirdly, Jesus said, love your neighbor as yourself. So take the vaccine. If you're not going to take it for your own self's sake, think about your neighbor, because you could be a carrier and you could give it someone and have fatal outcome. Think of the NHS. So love your neighbor as yourself. Do unto others as you would have them do to you. You don't want anybody to give you the COVID. You don't want to give it to anybody. So follow the advice of Jesus. Be your brother's keeper. Look after each other. Save the NHS from being overstretched. And God bless you as you do that.
And God bless you too. And thank you very much, Mike, actually, for hosting this. This is MANSAG, Medical Association of Nigerians across Great Britain. We're really looking forward to working together with our communities, with other doctors, nurses, allied health professionals all over the UK. So please, if you have any ideas or suggestions on things we can do together to improve a health-seeking behavior amongst every one of us, that would be great. Kindly email us at info@mansag.org. or contact us to Twitter, Facebook, Instagram, etc. And of course, we will be asking for your feedback regarding this session. We would like to know exactly what you think. Mike?
Just to say thank you so much for everyone. I've pestered many speakers, directly and indirectly. Thank you for being here with us and spending your time with us and sharing your knowledge. And thank you very, very much to everyone who's attended. We've had over 400 people, both here and watching on YouTube. No one is a sole fountain of knowledge. No one is a monopoly of knowledge. So let's keep sharing ideas and sharing thoughts and hopefully continue to improve behavior. Thank you all so much and have a lovely evening. Thank you.
Thank you so much, MANSAG. Please, let's keep working together with each other.
Thank you.
Thank you.
Thank
you, everyone.
Thank you.
Thank you.
Thank you.
Bye. Bye, Laura. Bye. Thank you. Bye.
you.
Thank you. Bye. Thank you, everyone.
Thank you.
Thank you.